My name's John Martin. I'm one of the joint surgeons focusing on hip and knee replacements at Central Indiana Orthopedics, based out of Central Indiana. Thanks for including me today and letting me talk about hip arthritis. So the first question I was tasked with is, when should you see a specialist for hip arthritis? And really, in my opinion, it's anytime. Anytime you're having pain around your hip, I think it's appropriate to see a specialist who manages and treats hip arthritis. Especially if you're having hip pain that limits your function and your quality of life, I think it's definitely important to see a hip specialist. And especially if you're in that category and you failed non-operative measures, I would definitely see a specialist who evaluates and treats hip arthritis. When it comes to hip arthritis, there's really two treatment categories. And the first one is conservative measures. So it's rest, activity modification, ice, anti-inflammatories like Aleve, ibuprofen, Motrin. I think physical therapy has a role for conservative measures, whether it's working on gait training and balance training, whether it's helping you use your assistive device if you use a walker or a cane, or even more high level things like strength and endurance training, flexibility. I think weight loss is definitely an option and it's a good option for conservative measures. Losing 1 pound of weight translates to 4 to 6 pounds of pressure off your hip joint. This is definitely a team-based approach through the physician, patient, nutritionist, and dietitian. And in my practice, I think corticosteroid injections are another conservative option that we have for hip arthritis. As Christopher was talking, as you have thinning of your cartilage, you end up getting inflammation, which causes pain in the hip joint. Steroid injections, in my mind, serve two roles. One, a therapeutic role where the steroid targets that inflammation and hopefully decreases that inflammation and decreases your pain. The second option and the second role for a steroid injection is diagnostic value. Typically, 90% of patients that I see in clinic have pain in one of three spots around the hip. Typically, pain in the groin or in that front pocket. Worse when you move your hip around, do activities like getting in and out of a car, up and down a step, usually is due to hip arthritis. Pain on the side of the hip hurts when you press there, hurts when you lay on it at night, it's usually bursitis. And then pain in your back pocket or that gluteal region, especially if it radiates down your leg, is usually coming from your back. A lot of people, their pain doesn't read the textbook and they can have pain in multiple locations. So I think doing a steroid injection into that hip to see how much relief one gets from their pain can be of great diagnostic value. Whenever you've exhausted all those measures, you have significant pain, it limits your function, it limits your quality of life. Then we start talking about the second treatment option in the form of a hip replacement. Hip replacement surgery entails removing the head and part of the neck, resurfacing the cup or the socket with a cup, and then putting a stem in the femur, and the head goes on that stem and articulates or goes with the cup. And essentially is depicted here in this X-ray. I like implementing robotic technology in my hip replacements. There are three main features of it that I find useful in my practice. The first one is it gives you a lot of information. It starts off by getting a CT scan of your hip in order to get 3D imaging. You can see this X-ray on the left is how we plan out our hip replacements if we're not using robotic technology. And then with the CT, it gives me information to best fit the components to that patient's anatomy and really customize where I think the components should go to best fit their anatomy and recreate their biomechanics. And you can see here that all these screenshots are tools and information that the CT scan's given me and the technology's given me in order to end up with an X-ray that looks like this. The second caveat of robotic technology is the dynamic joints balancing. So one thing we found in orthopedic literature is there's a lot of reasons why patients can be put at risk for dislocating their hip. And we found that one of the reasons that put patients at risk for dislocation after hip replacement is spinal stiffness from arthritis or a fused spine. This has been carried out in the literature. And in my practice, what I do is I get X-rays of the patient's lumbopelvic junction, so where their spine meets their pelvis. And I see how much it moves when they're sitting and when they're standing. I'm able to take that information and plug it into the software and the technology, and then run impingement free range of motion simulations. So based on how stiff their spine is, I can see where their hip would impinge or hit, and that puts them at risk of dislocating. With that information, I'm able to change the position of the components by a few millimeters or a few degrees to best lower the risk of that patient's dislocation. And the literature has shown that while using robotic technology, we can not only lower the risk of dislocation, but we can lower the risk of needing a revision or a redo surgery for dislocation. And the third part is carrying this plan out. So it's great to have this elaborate plan, taking into account the spine, change the components where you want them by a few degrees or a few millimeters. But it's tough to do that without using the robotic technology to that precise and that accurate a level. So the haptic technology allows me to remove the appropriate amount of bone, as well as put the components exactly where we want them and really execute that plan that we have. And so once we do the hip replacement, what can we expect after surgery? And so patients are usually up and walking the day of surgery using a walker. Patients either go home the same day or stay one night in the hospital, depending on several factors, from degree of how bad somebody's hip is to medical issues and comorbidities. Typically after surgery, like I said, you're using a walker, then you progress to a cane, then you progress to nothing. Some patients will have restrictions based on the approach that they get. Whether it's a front approach or a direct anterior approach, typically I don't have any restrictions for those patients. If it's a posterior lateral approach or a posterior approach, usually I'm doing 8 weeks of posterior hip precautions. I like outpatient physical therapy for hip replacements. That's controversial. I think getting up, getting ready, getting to therapy is life therapy. And then when you get there, working and walking and gait training is important. The questions I always get are, when can I go back to driving? Really, that it's two factors that allow you to go back to driving. One, you have to be off narcotic pain medications. And two, you have to be feeling comfortable to slam on the brake in case of emergency. Everybody's a little different. And when you meet those two criteria, I think that's when it's appropriate to return to driving. If we do your left hip, you end up going back to driving a little quicker than if we do the right hip. The other question is, when do I get to go back to work? Again, this varies. Everybody's different. Everybody has different jobs and physical requirements at those jobs. If you log on remotely, kind of like we're doing tonight, you could go back at probably 2 to 3 weeks. If you're slinging luggage at the airport, you may be looking up to 3 months. But there's always, again, everybody's different. And then people are usually returning to activities of daily living between 6 weeks and 3 months. And I think the total recovery time for a hip replacement is 6 to 12 months. Usually, again, in that first initial postoperative period, we're working on walking and gait training, but then we transition to strengthening and then stamina and endurance. And that's a whole year-long process. You go from seeing day-to-day and week-by-week changes or improvements to more month by month when you get into that 6th, 7th, 8th month time frame. And so I hope this was helpful. Thanks for letting me speak on hip arthritis, and I'll be happy to answer any questions in the Q&A. Thank you.